Today we have a slide seminar in head and neck pathology, especially oral cavity. It's not moving, sir.
Just click in the center of the screen. Click in the center of the screen and then move. Yeah.
Okay, sir. Today we have chairpersons, Dr. Anila KR. She's Associate Professor, RCC Trivandrum. And Dr. Shiva Kumar, Professor, Surgical Oncology, Head and Neck, TMH Mumbai. And our faculty, the teacher is Dr. Munita Bal ma'am, Professor, Department of Pathology, TMH Mumbai. And sir, do we need to introduce the students again? No need, no, sir. Can the students?
Quickly, Jasleen, quickly. Yeah.
Today we have and the students are Dr. Jasleen, third year resident from INHS Ashwani Mumbai, Dr. Rishabh, Dr. Kuljit Kaur from Ambala, Dr. Arshia from Basavatarakam Indo-American Cancer Institute, Hyderabad, Dr. Subhash, he's from Agra, Dr. Arju from CMC Ludhiana, Dr. Shruti, she's absent, Dr. Raghunath from Rajkot, and Dr. Pallavi from Guwahati Medical College. Our today's session's moderator are myself, Dr. Lopa, and Dr. Nishi. Dr. Nishi is Assistant Professor, AIMS, Deoghar. And there are certain reminders in case of connection interruptions, low or no sound or video freezing, kindly leave the meeting and rejoin the same link. And if problem persists, please check the internet connection. And any questions, please type in the chat box. Please do not send any requests for annotations to the presenter. There are disclaimers. There are a few more disclaimers. And our upcoming talks are in head and neck pathology, approach to salivary gland neoplasm by Anita Borges ma'am on 5th of December, and slide seminar on complete blood count by Dr. Kunal Shegal on 7th December. With this, let's start our session. Over to you, ma'am. Munita ma'am.
Hi, good evening, everyone. Am I audible?
Yeah.
Yes, ma'am.
And is my screen visible?
Not
you
yet.
have to share it. Raghunath, we can't see you and we can't hear you. You are muted again, Raghunath. Okay.
Now?
Yeah, no, not yet.
Yet, ma'am.
Ruchi, now it's okay.
Yes,
Perfect.
yes, we can see.
It's game.
Okay, so I can start?
Yeah.
Yes, ma'am.
Okay, thank you, everyone. I'm going to straight away start with the oral cavity cases. This is a slide seminar. And my disclaimer is that this is not a proper lecture and doesn't cover everything under the sun. And also that my experience mostly is in cancer pathology, but I do get to see benign also. So most of my experience is in oncology. Few of the images I have taken from internet for teaching. So case one, this is a 42-year-old tobacco chewer with ulcer in the tongue, and what we have is a biopsy. Who is going to discuss this case? Maybe a second year, Kuljit? Are you there?
Ma'am. Yeah.
So if you get a biopsy like this with an ulcer in the tongue, what is the clinical question in this case? What do you think you want to look for? Straight away, what is your question?
Ma'am, I would ask if are there any dentures? Do the patient have any dentures? Was there any accidental bite? Or the ulcer, is it like from how long the ulcer is?
Okay, so these are the questions that you have, but what do you think is this biopsy come with a question of? So what is the question in this biopsy? So if you don't have any information, what do you think is the primary question? What is the clinical question? What does the clinician, why has he sent you this biopsy? If you don't have any more information than this, right? You have a long list of questions that you want to ask upfront. But the only information that you have is this guy is a middle-aged tobacco chewer, has ulcer in the tongue. And now the biopsy has been done. What do you think is the clinical question here? Primary clinical.
Maybe they want to rule out the cancer.
Yeah. So first thing would be that first primary question would be like, is it malignant or not? So do you have any approach when you deal with a biopsy from an oral cavity lesion? Do you go follow an approach?
Yes, ma'am. I think we start from the epithelium, seeing the various changes, and then sorry.
Yeah, go
Yeah.
on. We can hear you.
Okay, so ma'am, I think we should start from the epithelium and see what all changes the epithelium has, and then subsequently going downwards in the submucosa and later on. Like if I take this biopsy, the very first thing that struck me was this acanthotic epithelium, which was mimicking like it is a carcinoma, but subsequently I thought it to be a pseudoepitheliomatous hyperplasia only. It was like we had these interconnected gritty ridges which was bulbous and they were projecting downwards. Also, I can see was a area of ulceration along with the granulation tissue. That's all I can make from this very picture.
Okay. So when you get a biopsy, your main approach is you first look at the epithelium and then you look at the subepithelium. Is that correct?
Yes, ma'am.
And what are you trying to do when you're trying to look at the epithelium and the subepithelium?
Ma'am, first I would like if I go with the epithelium, the very first thing I would like see whether it is because of any infection or something. So I can go with like if like the epithelium can be reactive because of some fungal pathology as well. So I need to rule out it directly going to the carcinoma, I guess.
Okay, okay. So your broad categories you want to first see is it malignant? And then if it is benign, you want to see what is the cause of that benign ulcer. Is it some infective etiology or some reparative or reactive etiology, right? So here
Yes,
you say that you've seen your main focus was that this epithelial proliferation because that is so prominent. But then you see that there is a downward. I can't use this pointer very well.
Pointer options. You can use the laser.
Okay, is this better?
Yeah.
Okay. So you can see that there are these downward proliferations of epithelium. So epithelium is hyperplastic or it is much more proliferative, but you can see they are still very regular and downward projecting, and some of them are interconnected. And why do you think this is pseudoepitheliomatous? What do you mean by pseudoepitheliomatous? Somebody else can tell me, the other second year student, maybe Pallavi? Why is Puljit saying this is pseudoepitheliomatous? I think this proliferation is looking very abnormal, too much. Do you think this is too much? When would you call something pseudoepitheliomatous?
Epitheliomatous proliferation can be seen in various reactive cases, ma'am, like infections.
Okay, but why do you think this? Do you think this is pseudoepitheliomatous proliferation, or you think this is suspicious for malignancy or malignancy?
Ma'am, in these cases, we can, in these slides, we can see, ma'am, epithelial hyperplasia, and then in other slides, we can see, ma'am, fibrom,
Okay.
The hyperplasia of the fibroconnective changes. And in other slides also, we can see the
Okay, we
inflammatory
haven't gone
cells.
to the next slides, but what we are basically seeing in this lesion is one. What do you think is the main lesion, Pallavi? Is it the epithelial hyperplasia or something over here?
Yes, ma'am. Epithelial hyperplasia we can recognize by the slide, ma'am.
Yeah. So the main lesion, which is the abnormal lesion, is is over here on the bottom side, right? And what you're seeing is the changes in the adjacent epithelium, right? So the main lesion, what the clinician has biopsied and is wanting to know, oh, am I not sharing the content? Is what has happened? Is my slide visible?
No,
No.
no, ma'am.
No, you have to, I think, log out. You have to stop sharing and share again.
Okay, resume.
Just
No.
stop sharing.
It is stopped sharing. It's already
Now.
showing it is
Yes,
stopped.
now you can share again.
What should I do?
Share again now. Share the slides. Your presenter. Share.
No, it is just saying stop sharing. There are two options, resume and OK. And both of them are, nothing is happening when I'm clicking.
What does it show when you click on sharing?
I'm now try it. Please try again.
Should I exit and come back again?
You
Yeah,
can do that.
that should be better, no?
Do
Yeah,
that.
that should be
Log
better.
out, log out and join again.
Okay.
In the meantime, Anila can, if you want to say something to students, you can talk. Anila.
It's just not switching on somewhere.
You can maybe
Yeah,
log out and join again, Manita.
I'm not even out.
You can log out means you don't see a cross X
So
on the red cross.
no, I mean, nothing is working. The whole thing is hung. Is my screen still not visible? No.
No, ma'am.
We
no.
can see you.
No, ma'am.
You have to.
Let
I'm
me
logging
see.
out and then
Yeah, you log out.
rejoining.
You log out.
Dr. Anita, you can please pitch in.
Yeah, yeah. I think Kuljit was discussing initially, so maybe the clinical, I'd like to ask Kuljit, like for an ulcer, as Dr. Manita was asking you, what are the clinical details that you would be asking your clinician or the surgeon who has sent you
Ma'am,
the
your
biopsy?
Now you have
Screen
said.
is shown.
आ गया, Manita.
Yeah,
Okay.
so we'll continue later. Yeah.
Okay. Okay, thank you. So what is the main lesion that the clinician has biopsied is the ulcer. So he wants to, or he or she wants to mainly see when they see a patient with ulcer. And probably we'll ask Dr. Shiva later which type of ulcers they actually biopsy, because not all ulcers would be biopsied. So once they've biopsied an ulcer, they want to know whether that is benign or malignant. And if it is benign, then obviously we can work out what is the cause of that ulcer. But if it is a malignancy, then they need to plan resection and so on. So the main lesion that is biopsied is the ulcer. And then that whole epithelial proliferation that you are seeing is the adjacent changes that are seen. So this is something that will not cause too much of clinical or macroscopic lesion. What is basically being sampled is the ulcer, and you have to, that is your primary lesion, right? So many times my residents will write the report as hyperplastic squamous mucosa with underlying inflammation. So if this is not exactly the accurate way of describing it, what we see here is that here there is no epithelium, and you can see some exudate here, which we'll see in the next slides better. And there is a whole lot of tissue here, which is very cellular, and there is a lot of adjacent mucosa, which almost looks normal, but it is only abnormality is it is much more proliferative, or it is much more than what we normally see. So that is the adjoining, and this is the main lesion. And if we, is it moving? Okay. So if we look at the higher part, we will see that here this tissue is covered. You don't see. So here, this is a normal tissue or normal epithelium, which is crept up in the biopsy, but the main lesion is this, right? So first is identifying what is a normal tissue and what is the abnormal tissue. And if you see in this abnormal tissue, you don't find any lining. But what you find is what you think is where is the lining of this Pallavi or maybe Shruti? So do you see a lining in this tissue bed?
No, ma'am.
No, no, ma'am.
So what do you see instead?
There is ulceration of the lining. The lining is
Ulceration of
separated
the lining and
from the underlying
denudation.
tissue.
Okay. And what you see instead is actually it is covered with a thick pinkish membrane-like covering.
Yes,
And what do you
ma'am.
call that covering? Or that thing which is covered where normally there should be a mucosa, but now instead of that normal lining, what we have is a covering, which is very pinkish. What would you call that?
Denuded epithelium.
Okay. So what? Okay. Maybe I should have. Yeah, anyone else wants to answer? Okay, maybe here is a better picture where you can see the
Granulation tissue. Okay.
Okay, so what you are basically saying is there is the whole substance of the lesion is what you refer to as granulation tissue, and we'll come to it why. And this is the layer which we see on the top. Can anyone describe how would you in pathologic terms describe this layer? So this is a layer where the epithelium had to be present, the lining epithelium, but instead now you see a lot of pinkish stuff, and that pinkish stuff is fibrin, right? A lot of fibrin, and you can see some cells, dot-like cells in between. Those are just dead polymorphonuclear cells. So what is this labeled as? This whole thing is... So exocytosis is something that you see when you say inflammatory cells are infiltrating the intact epithelium, right? So this is where you don't see an epithelium and you see fibrin and you see neutrophils, which are mostly dead, degenerated leukocytes. So this is something which we call as an exudate or a fibrinopurulent exudate, right? And the importance of this is from when you're looking at biopsy, you will be able to see that there was a surface over here, right? So this whole thing tells you, it kind of orients for you that this is the area where normal mucosa should have been there or some lining should have been there. And now it is covered, ulcerated and instead covered with covered with fibrin and which is called as the exudate. So this whole layer, thick layer of membrane, which is covering there is the exudate, and it tells you that there is an ulceration over there, right? And underneath this ulceration, what you find is a tissue which is showing a lot of inflammatory cells as well as some areas which are more cellular. So what do you expect when there is ulceration?
Inflammatory cells will be fibroblast proliferation and neovascularization. Proliferating bundle.
So Arzu, I can't hear you.
Sorry, ma'am. There will be inflammatory cells. There will be fibroblasts that are proliferating, and neovascularization will be there. Small blood vessels will be present.
Okay, excellent. So what Arzu says is that when there is ulceration, the tissue the host tissue will try to repair it and will lead to neovascularization. So what she basically listed is basically the repair tissue, right? So you have new blood vessels and you have fibroblastic proliferation because that ulcer has to be bridged. And this is how who is the next person who can describe this slide for me? Arshia? Yeah. What do you see here? There's a lot of proliferation happening here. What are these structures? Can you identify them? Arshia? Okay, Raghuveer.
Arshia muted. I think no.
Raghunath.
Raghunath is muted. I think he's absent. He's there, but hi, Raghunath. Can you unmute yourself? Raghunath.
Raghunath, what do you think you can see in the slide? This is the main substance of that ulcer, the stroma underlying that exudate. You have this kind of lot of cells in here. Can someone, okay, maybe Subhash can pitch in.
Ma'am, numerous blood vessels can be seen and fibrous tissue can be seen here.
Do you think these blood vessels are different? They're hardly recognizable as blood vessels. Normally, you have patent lumen, you have blood vessels have a lumen, right? Are these blood vessels anyway different?
Neovascularization, ma'am.
What do you mean by
Proliferating blood.
neovascularization? Why are you using that term? What do you mean? What do the neovascularized blood vessels look like compared to the normal capillaries and normal arteries and arterioles? Are they different in appearance that you were trying to say? So are these blood vessels different in appearance, in morphology or appearance than the normal blood vessels?
Yes.
Yes, I think so, right? Normal blood vessels don't look so closely. I mean, their lumen are usually patent. And you have here, you can see there are hardly any which has a patent lumen, just a few holes here. And they are very small, narrow caliber vessels with very prominent endothelium. So the endothelium is much more plump and prominent than normal endothelial cells of normal blood vessels, capillaries, and because these are actively involved in transport of neutrophils and various inflammatory cells, as well as they have an active role in this inflammation. So they are very plump, right? So this is the difference between, and sometimes you can't see their lumen, so they look like closed blood vessels, and sometimes they can be very difficult to recognize as blood vessels. And what is happening here to the architecture? Do you think there is a lot of vascular proliferation? You can see that here, you can see some lumina, some channels. But do you think there is what is it, a hemangioma, or do you think it is there is some vascular malignancy happening? How would you distinguish that this is benign versus a malignant proliferation? Does anything in the picture here tell you that this looks benign versus malignant? Rishabh?
Yes, ma'am. Ma'am, we can see proliferation of vessels and fibrous stroma. To call it a carcinoma, I'm not able to identify any nest of cells or any proliferating cells.
Yeah. And another thing that you can see is that there is a bit of lobulation. Whatever proliferation is
Architecture
happening.
is maintained.
Yes. So kind of the whole thing is in a way lobulated, right? So there is no haphazard, or you can't see any islands, and you are basically seeing a lobulated architecture. And what's happening to the epithelium here? Again, is this normal epithelium? This doesn't look like a normal epithelium, right? There is slight abnormality that you have these kind of saw-toothed or jagged edges, right? So this is again an active epithelium which is responding to the ulcer and the granulation tissue, and it is showing pseudoepitheliomatous hyperplasia, right? So there are these thin cords which are coming out, and the epithelium, oh, where is my pointer? Sorry. Here, right? So there are thin cords. So this is what is expected in the adjacent or the overlying epithelium. The epithelium tends to proliferate. It has to bridge back and rebuild the epithelium over the ulcer. So it starts proliferating, and underneath you have this granulation tissue, which is mainly a lot of vascularized new blood vessels as well as a lot of collagen. Do you think the stroma is a little altered?
It appears desmoplastic.
Does it? Okay, so desmoplastic is a strong word here. So what you do have is basically a lot of myxoid change, right? So generally the ulcers in the initial phase tend to have a lot of edematous stroma, right? So the stroma has less collagen, more edema fluid, more inflammatory cells, and it slowly starts becoming very myxoid, and then it has to the repair tissue tends to, if the ulcer is deep enough, then it will become fibrotic and form a scar tissue, right? So some of the blood vessels, here you can see these structures, which at low power sometimes can be so dark that they can look like glands, right? So sometimes the blood vessels, because what happens in an ulcer is that there can be a lot of inflammation. So the epithelium also starts showing some degree of nucleolar changes. Nuclei become enlarged. That is called as reactive atypia, as well as the endothelial cells, as well as the fibroblasts. They will show some degree of atypia in the form of they are sort of reacting to the inflammation and to the insult to the surface. So they start showing atypia. Their nuclei are enlarged. The cytoplasm in general is more basophilic because it has more RNA. It has to lay down more collagen. So fibroblasts, myofibroblasts, this is the cellular composition of an ulcer granulation tissue. But the problem with this is that these endothelial cells can look really sinister. So they can have the endothelial cells can look very dark and hyperchromatic, and at low power they can look like glands. And in a thick section also they can look like malignant cells because of hyperchromasia. And what is happening over here? Again, here you can see a lot of endothelial cells here, but if you can see these new blood vessels, where is the pointer? Oh, okay, sorry. So what is this cell here? I'm sorry, I'm very unfamiliar with this pointer. Here, this one. So can you see there are some very atypical cells in the stroma? No one volunteers, huh? Justly, do you think there are atypical cells in this, or we can ignore them?
Ma'am, I could appreciate necrosis, like neutrophilic infiltration is there.
What do you mean necrosis like?
Ma'am, there would be presence of neutrophils.
So neutrophils is not equal to necrosis, right? Necrosis is when you just see a granular debris of dead cells, right? So when so neutrophilic infiltrate is there. You can see these kind of rounded structures, which are blood vessels. And you can see there is kind of concentric myofibroblasts and fibroblasts around these blood vessels, which give them a kind of onion skinning appearance. So that is a helpful feature that these are endothelial, these are blood vessels and endothelial cells. You are right, there are lots of neutrophils which are spilling out into the stroma and through these blood vessels. But you also see these kind of atypical cells, which are what is the shape of this cell?
Ma'am, it is spindle shape.
With the plump
Yeah, so it is much more plump than the regular spindle cell. So this would be a spindle cell here. So this has a more stellate or a triangular kind of, it has these kind of fibers coming here and here. It is more stellate and more triangular rather than a regular fibroblast or a spindle cell, which is you can see in connective tissue, those various fibroblasts here, which are more spindle, but this shape is more stellate or more star-like. It has these kind of projections like star, and this cell is a myofibroblast, and it is a cell, it's a repair cell, right? So wherever there is a repair happening, it will be present. It is larger, more cytoplasm than a regular fibroblast, and and the thing is that they can sometimes look very blue, and because of more RNA in their cytoplasm, and they have nuclei which are showing reactive changes because they are actively involved in the part of inflammation, right? So they can show smudginess of nuclei. Nuclei can look much more darker and more blue, and it can attract your attention. So what we do see in this whole thing is that we see these blood vessels. They are recognizable because they have this kind of concentric appearance, and they have these plump endothelial cells. And we should be mindful that their plump endothelial cells can look hyperchromatic, and they can look like glands at low power. And the blood vessels may not actually show lumen. They are very close, right? And you have a lot of inflammatory cells. And you have this kind of stellate cells which can show, or the stromal cells which can show atypia. So when there are a lot of these cells, then you start wondering whether there is malignancy in this or not, right? So one of the chief goals is to see whether there is a malignancy in this or not, right? And what do you see? What else would you see when you see? Okay, let's see this slide first. Again, this slide is much more cellular. Who is the one who has not participated yet? Shruti? Shruti, what do you think this slide is showing? There
Shruti
are
is
too
not
many
here.
cells.
Shruti is not
Okay,
here.
okay, so maybe we can go back to Arshia.
Yes, ma'am.
Yeah, there are lots of cells in this. This is looking very cellular and very scary to me. Does
Yes,
it
ma'am.
scare you also?
The cells as such, ma'am, they don't look, there is not much pleomorphism, ma'am. We
Okay.
can see this stellate cells, I mean, like, and myofibroblast, but I don't see much pleomorphism between one and the other cell.
So what do you mean by pleomorphism here?
Pleomorphism, madam, one cell will be like small and other will be big, and the nuclei will be different. Some nuclei like vesicular nuclei and opened up chromatin, conspicuous nucleoli, like, and also we can also like pleomorphism, we can also appreciate this mitotic figures also, ma'am, with atypical forms. Those kind of things I'm not appreciating in this like in this slide, ma'am.
Okay. Okay. So Arshia, can you summarize what we have seen and why do you think this is benign or malignant in favor of what? What are the things that you would what you have seen which tells you that this is not a malignancy?
Yes, ma'am. First, ma'am, like coming to the epithelium. Epithelium, first, it looks ulcerated, ma'am, on one place, and other places, some part of the epithelium is thinned out, and some is showing pseudoepitheliomatous changes, ma'am. And coming to the subepithelium, I'm seeing this lobular configuration of there is proliferation of vascular and endothelial cells. And then stroma is myxoid, ma'am. Stroma is myxoid. So putting all these things together, I favor like a benign pathology, probably like a exuberant granulation tissue. And stroma is also showing a lot of inflammatory infiltrate, ma'am, neutrophils, lymphocytes. So
you think
that's
this is
why.
not a malignancy, right? Because you're not seeing anything. What would you see in a malignant ulcer?
Yes, ma'am. Malignancy, first of all, we can appreciate, ma'am, whether like if it is coming from the epithelium, we can see this squamoid nest, and those nests will be infiltrating, ma'am, and they can show this pleomorphism. We can see with keratinous differentiation will be there, ma'am, at various levels.
So
So
you're not
that.
seeing all this, and you are seeing mainly a proliferation of granulation tissue and epithelium, which is showing some abnormality, but not so much cytologic, only architectural abnormality you
Yes,
are
ma'am.
seeing,
Architectural.
right? And you are seeing some stellate cells, which we think look more like myofibroblast because of their stellate shape, as well as a lot of fibroblasts, and they are probably showing some atypia, but there is not much marked cytologic atypia, right? And we don't see any epithelium which is proliferating. So we think it is benign ulcer. Would you look for anything in a benign ulcer, or that's enough? Negative for malignancy.
Ma'am, I would also look for like micro organisms, ma'am, like
Yeah. So you would like to
mycobacterium,
rule out an infective cause.
infective etiology, ma'am.
Okay.
So I would like to.
Rishabh, can I bring you in? What
Yes, ma'am.
infective, what would you look for to rule out various infections? What all can you see?
I don't know.
Okay, you don't know. So, okay, so you can look at Anjasli.
Ma'am, we will look for clinically, we can look for discharge, presence of discharge, and mouth opening of the patient if the patient is able to, if there is any associated fibrosis or not.
Okay, so you have, okay, we can go back to Arshia. Maybe you can elaborate what you were saying. So we can go back to the clinical later. So what are the infective etiologies that you can see? So you can look for, one you said is Candida, right? So you can see, look for Candida fungal hyphae and their pseudo hyphae. in the exudate or in the tissue, right?
Yes, ma'am. We
Viral
can also look for
HPV.
mycobacterium, ma'am.
Who's mentioning HPV?
viral cytopathy.
Ma'am, HPV.
HPV, okay. So HPV, oral HPV, okay. So uncommon, but you can have, it's oral mucosa is an uncommon site for HPV. You can get some warts maybe and papillomas, which can be associated with low risk HPV, but that's not common. So what common conditions can we see in the oral cavity? So we can look for granulomas, right? And we can look for, okay, let's see
Yes.
what all we can do when once we see this. So we've seen this, if we summarize this, which is summarized nicely by Arshia, we basically see an ulcer here. This is the main lesion. And you see adjoining epithelium, which shows architectural abnormalities in the form of this kind of this kind of abnormal bulbous retipex, which are interconnected. This we interpret as pseudoepitheliomatous hyperplasia. Not much cytologic ATPI is seen here. And then we see again lobulated architecture. And we see this covering, which is the fibrinoporulent exudate. We don't see any organisms here, but we can in a fungal ulcer. And then we can see vascular proliferation, and which is this low power appearance of a lobulated architecture helps us in looking at big ulcers. They in benign you will see a lobulation usually, and endothelial cells can show marked atypia, and we have to be careful. And sometimes you will see scattered stromal cells and myofibroblastic cells, which can show some degree of nuclear hyperplasia or atypia, especially when there is some traumatic ulcer. And so what we see when we see it, the ulcerative lesion is we look at the surface and we try to, we also see what is the epithelial component showing and what is the stromal component showing. And when you see an ulcerative lesion, you will basically try to see either some of them are clearly malignant, like Arshia mentioned, that you will see some frank invasive islands of epithelial cells, which are infiltrating way deep into the tissue, and you can see a lot of architectural complexity. You can have islands which are infiltrative, they are separated from each other and going deep down. And this is usually a clearly malignant epithelial proliferation, will show a lot of cytologic atypia and pleomorphism. You are not questioning the atypia most of the time. And the stroma is desmoplastic, and desmoplastic stroma, unlike a quiescent stroma, with very slender fibroblasts, desmoplastic stroma is much more active. It is much more cellular. It has plump fibroblasts. So whenever there is invasion, there is a host reaction of desmoplastic stromal reaction, which is actually very helpful in picking up the areas of invasion. And with pseudoepitheliomatous hyperplasia, you will not find this kind of reaction. And mitosis, especially, you don't look for mitosis usually in a frank carcinoma, but when there are problem areas, you will find a lot of atypical mitosis also. And on one hand, you can have an ulcer which is clearly malignant, and then you can have a clearly benign ulcer. Like so, in the malignant, like we see here, you can see there is an ulcer. Again, there is some degree of epithelial proliferation in the adjoining, but you can see deep down there are a lot of epithelial islands which are haphazardly proliferating. There is no architecture, there is no lobulation, and these are infiltrating mindlessly into the underlying connective tissue, and they are of different sizes, and if they are accompanied by a fibroblastic reaction, right? So most of the times when we have clear-cut malignancy, we forget the adjoining epithelium, we forget the overlying granulation tissue, but it is when we don't find a frank malignancy, we then start looking at these adjacent whatever epithelium we have in the biopsy. So in the clearly benign ones, what we see is that you don't see any abnormal epithelial proliferation going deep down, right? So that kind of architectural complexity where you have irregular islands infiltrating deep into the tissue, that is not there. Overall architecture you'll find is much more lobulated. And you'll have this, usually there is a lot of endothelial proliferation. You can see a lot of endothelial proliferation, and those endothelial is what the students mentioned are neovascularized. They have much more plump endothelium, and the stroma is tends to be more edematous and full of inflammatory cells, and less. There is not much desmoplastic reaction, and there are no atypical mitosis. And then you can look for the causative agents. You can find granulomas, and there are many causes of granulomatous inflammation, uncommon in oral cavity, but you can find tuberculosis or sarcoidosis. You can have granulomas associated with fungal infection. You can have also granulomatosis with cholangitis, previously known as vaginas, or you can have various other vasculitis. And then in the exudate, you can look for these organisms. Usually, you will have a history of clinically fungal ulcers are easy to diagnose, but you can confirm them. Here, you can see a lot of fungal profiles in the exudate. This is one of the cases. So you can see a whole lot of organisms in your ulcers, and this is one of the cases which showed. Can anyone, would anyone more like to make a guess what this is? So you can see there are some dot-like structures here. Anyone can make a random guess?
Aspergillus.
So, okay, aspergillus, we see in aspergillus, we see hyphae, right? We see long hyphae. Here, what we are seeing are actually dot-like structures. So something very good, very good. It is something which resembles antibodies. So this was a rare case of histoplasmosis. So this is positive for silver stains, GMS, and PAS. So sometimes you will get some fungal infections also. So if we are only looking at low power and saying this is a benign ulcer granulation tissue, we should, once we say benign, we should also try to see what is the cause of this ulcer. Is there any infection? Because if you can find an infective cause, then you can treat it, right? So, so this was a rare case where you can find organisms. So this was histoplasmosis, and you can see these, and it does resemble LD bodies, and there is a whole separate check. And rarely you can also find syphilitic ulcers. And what you typically see is the typical microscopic appearance is actually non-typical. It shows mainly plasma cell-rich infiltrates, dense infiltrates. Oral syphilitic ulcers are pretty uncommon, but some off and on they are reported. And for them, the diagnosis is made on immunohistochemistry you require, or clinical serology you need for treponema pallidum. So you can get various organisms leading to ulcers. And some of the clues are, if you get granulomas, it could be tuberculosis. In fungal infections, you will get eosinophils. And in viral infections, you can get viral inclusions. What are the viral infections that can occur in the mouth? Jasleen?
Herpes simplex.
Okay, so what do you see in herpes simplex? Any typical appearance of the herpes?
Ulcer,
I don't have the
mucosal
inclusions.
ulcerations. Painful mucosal ulcerations.
Okay, that's good. So what you can see in the microscopy is you can see those nuclear there are nuclear inclusions. There is multinucleation and nuclear margination, and you can see those kind of features in herpes, right? And you can see in CMV inclusions where you can have cytoplasmic and the whole cell is enlarged. I'm sorry, I did not put the pictures, but the main thing is that you can when you see ulcers, when you are not seeing malignancy in the benign ulcers, go a step forward and try to see if there is any infective etiology, and because that can be then specifically cured. Anyone wants to take a guess at what could this be? Anyways, so sometimes you will find some non-infective conditions also which can lead to ulcerations in the mouth. So here you can see that there is only the basal layer you can see. The epithelium beyond it is not there, right? So this is a vesicobullous disorder. So this is pemphigus, where you can see suprabullous So sometimes we are just concerned with, sometimes you may not even realize that this is the whole epithelium has been stripped off, right? So that may be stripped off because there is clefting at the level of there is a suprabasal bulla. So the clefting is at the level of above the basal layer. So these are some of the things. So this is a this is bullous pemphigoid, where you have, again, you may totally miss this, these conditions. And then you have traumatic ulcers. One of the important thing is that this is the information that clinicians can give, is whether there is any ill-fitting denture, jagged tooth, because that is pretty much common in the clinical scenario that you have ulcers due to trauma. And in cancer center where I work, there are a lot of ulcers post radiation, and so they can also look very, very sinister because of lot of stromal atypia. So some of the ulcers can be clearly benign and some of the ulcers can be clearly malignant, but then you can have ulcers which can show epithelial atypia, which can show endothelial cells can show atypia, stromal cells can show atypia, and you can sometimes have, also you have to look at the immune cells, whether they are normal or they are abnormal. Right. So one of the things is that sometimes we will see in the fibrinopurulent exudate, a lot of cells are there in the fat, which we find they are very atypical. So we have to be very careful. The shed cells which are shed in the exudate, we should not overcall malignancy in that. So malignancy diagnosis is to be made in the tissues, right? Not in the shed degenerated cells, because as soon as when there is ulcer exudate, you can have a lot of desquamated shed cells in the exudate, and we tend to, and because they start degenerating as soon as they shed, they can look very dark and hyperchromatic, and that's in fact degenerative atypia. So be very careful and not overcall malignancy when you are seeing only atypical clumped up cells in the exudate. So don't call something in the exudate. You try to look for in the underlying tissue that there should be invasion. And another important thing which we have already touched is a lot of problems which are caused by pseudoepitheliomatous hyperplasia. When we don't see clear-cut malignancy invading, we start looking at the epithelium, whatever is available. And many times next to the ulcer, there will be a lot of abnormal proliferation. And some of the key features that help us is that in pseudoepitheliomatous hyperplasia, there is a abrupt transition from the ulcer to the pseudoepitheliomatous, and you can also see and also you need to know what is the spectrum of pseudoepitheliomatous hyperplasia. You can see a lot of elongated bulbous retipex. You can see a lot of hyperkeratosis. Sometimes these retipex can be quite bulbous, and but you can see they are still superficial and not evoking any kind of desmoplastic reaction. So features that help you decide that this is not a malignant proliferation from the epithelium but benign is that they tend to be pseudoepitheliomatous hyperplasia shows abrupt transition. It tends to be symmetrical. It has these kind of jagged edges or sawtooth appearance. Then you can see interconnected rete ridges. And you can see these elongated, sometimes you can see bulbous retipex, and sometimes you can also see, these are the retipex, right? So and these can be very bulbous sometimes, and sometimes you can see some keratinization also. And usually this will be associated with a lot of inflammation. So what you don't see is atypical mitosis. You don't see too much pleomorphism and atypia. You can see inflammation-related atypia in terms of if the nuclei are slightly enlarged, they become more vesicular, nucleolar prominence is there. But you don't see pleomorphism the way Arshay explained, where you have a lot of hyperchromasia and cells showing a lot of pleomorphism, and then desmoplastic reaction. You don't see too much deep invagination also. So a rough rule is that if you see some epithelium deeper than 3 to 4 times the thickness of the adjacent epithelium, you know that is quite deep enough, right? So that is something which is worrisome. And then if you start seeing epithelium which is going up to the muscle, right? So that is also there. And usually we don't have to do P53. Most cases on morphology you can make out, but sometimes there's a lot of proliferation. Then if you find there is diffuse P53 expression, that also favors malignancy rather than pseudoepitheliomatous. In pseudoepitheliomatous, the P53 will stay basal. Tangential cuts can be dangerous. So some of the slides I'm showing just to show how ominous and sinister pseudoepitheliomatous hyperplasia can look. In our index case, it was still very benign, recognizable, something that you regularly see. But some of the examples I'll show are the ones where pseudoepitheliomatous hyperplasia can take away your attention completely away from the main lesion. So this is look at because of the tangential cut, you can see that there is the proliferation of the squamous is looking very, very abnormal and infiltrative. And this is the same pseudoepitheliomatous case where you have histoplasmosis. So this was a case where sometimes the infection itself will evoke a lot of hyperplasia in the adjoining. This is another case where we had this is from the nasal cavity, but I'm showing this here that we had a nasal bleeding, but this patient was called as squamous cell carcinoma because there was a lot of epithelial proliferation. And if you see this does look very atypical. But if you look at this, they are mostly showing more pinkish cytoplasm, not much pleomorphism, and a lot of inflammation. And while the biopsy was called squamous carcinoma, a repeat biopsy when it was done, it showed a lymphoma underneath that squamous proliferation. So this was a T-cell lymphoma where the overlying epithelium was so hyperplastic and reactive that in the biopsy, the whole attention was taken away by this epithelial proliferation, and we did not pay any attention to the underlying lymphoma in the initial biopsy. And look at this proliferation. You can have these kind of pearls also, but if you look closely enough, the nuclei are still not very pleomorphic. They are not very abnormal looking. You can see nucleolar prominence, some kind of vesicular change and enlargement. But overall, the epithelium architecturally is very abnormal, but cytologically is not so abnormal, right? So this was a case which was pseudoepitheliomatous hyperplasia, which was florid, but in a case of lymphoma. So in the edge of the ulcer also, you can see a lot of angry looking epithelium. Try not to interpret when the epithelium, it's like a volcano which is exploding. Subhash, you want to say something?
Ma'am, visual are not synchronizing.
Oh, so is there a lag?
Yes, ma'am, lag.
Okay. So what are you seeing now?
Ma'am, fibrinopurulence exudate.
Excellent. So there I am showing you fibrinopurulent exudate, and you can see at the edge of this there is epithelium which is somewhat remaining and residual epithelium of this ulcer, and this is looking very abnormal, but we have to be just aware that there can be a lot of abnormal looking, angry looking epithelium adjacent to an ulcer. Another scenario where can anyone, so you can see that the whole attention we can see is in this epithelium, which is much more hyperplastic. The edges are much more ragged and jagged, right? So is there anyone who can see anything more than that? Okay. Now, so in this, is it synchronizing?
Yes, ma'am.
Okay. So can anyone recognize is there something in the stroma? Third years?
Myxoid appearance.
Okay, excellent. So we do see some abnormality, right? So you see some collagen, native collagen, and you see some myxoid appearance. Now, on higher power, you see there are these kind of cells.
Granular
Yes.
cells.
Excellent, Arshia. So these are cells which are showing granular cytoplasm, right? And they are, if you look here, you can hardly make out these cells, right? All your attention is on this epithelium, which is very pseudoepitheliomatous and hyperplastic. And here you see underlying there are these cells which look inflammatory cells, and when you look at them, they are quite granular, right? So this is a tumor which is notorious for being and this is a tumor which is called as the granular cell tumor. It has these infiltrating cells in the subepithelium, and these are highlighted by S100 diffuse positivity. And what is remarkable about this is that this is typically associated with pseudoepitheliomatous hyperplasia, and the tumor itself can be very, very well hidden. So on account of both these things, it can be misdiagnosed, because you can see the tumor is only seen as very bland looking granular cells. And here also you can see, right? So this is one tumor that we need to remember, which is classically associated with pseudoepitheliomatous hyperplasia. So these are cells which look very histiocytic, and they can be mistaken. The granular cell tumor can be totally missed because it is very well hidden in the underlying subepithelium, and the pseudoepitheliomatous hyperplasia can be mistaken for squamous carcinoma. So that case, the pseudoepitheliomatous hyperplasia was not that dangerous looking. This is another example of granular cell tumor. You can see that in the subepithelium, you can hardly see the tumor. It is just looking like collagen, or just looking like you're not even realizing that there is a tumor here. All your attention is on this kind of atypical squamous proliferation on the surface, and you want to know that whether this is squamous carcinoma or not. So mind you, this is pseudoepitheliomatous hyperplasia, which is very typically seen with granular cell tumor. And the epithelium is otherwise bland looking, but very architecturally abnormal. And underlying, you can see this very hidden granular tumor. So this is a granular cell tumor. Okay, so it tends to take away attention from the main lesion. So you should be careful about this. And when you see a lot of abnormal proliferation at the surface, which is architecturally very abnormal, look under the surface also. So this was another case where we had a lot of abnormal proliferation, but there was a lot of inflammation also. And this was also clinically, this was destroying the mandible. So this was reported, this kind of abnormal proliferation, thick retipex, was called as squamous cell carcinoma on the biopsy. And this later on we realized that there was this kind of island with a lot of myxoid change, and in the final resection it turned out to be a ameloblastoma with here you can see this is acanthomatous ameloblastoma, but here in the biopsy the overlying epithelium was so hyperplastic that it took away the entire attention, and we misdiagnosed this case as a squamous carcinoma. Right, so pseudoepitheliomatous proliferation with in ulcers can be really problematic. We have to pay attention to the also the endothelial proliferation. So not only the epithelial compartment, the stromal compartment, the endothelial proliferation can be florid. You can have so much cellularity, and these can sometimes look like glands also. And you can recognize them by these kind of concentric onion staining, which tells that this is endothelial, and it is expected. This kind of atypia in a granulation tissue or in a reactive ulcer is expected. So you can see even the stromal cells can show a lot of atypia, and they can be hyperplastic, and they can be larger than normal fibroblasts, and can show degree of atypia, right? So how would you distinguish this from reparative myofibroblasts from sarcomatoid carcinoma? So sometimes you know that when you have a lot of atypical spindle cell proliferation in the oral cavity, and the clinical scenario is a recurrent non-healing ulcer. So you want to know, is it a sarcomatoid carcinoma, which is showing a fibroblastic phenotype appearance, or is it a reparative myofibroblastic proliferation? That can be a really challenging scenario. Anyone wants to make an attempt at, are we 1 hour down?
Yes, ma'am.
Okay. Okay, I think I'll only So if we want to come, one of the challenging situations that we face, especially in post radiation, is distinguishing the atypical reparative myofibroblastic proliferation from sarcomatoid carcinoma. We have to rely on the clinical picture also, whether this is a proliferative lesion, whether this has been progressive. That information many times is not available. So what it helps is if in sarcomatoid carcinoma, the quantitatively the abnormality is much more. So you will see much more spindle cells, much more cellular areas help you to favor a sarcomatoid carcinoma. The quantitatively the ATPI is much more. And then we look for atypical mitosis. So if you find atypical mitosis, by which I mean that you find a tripolar, unequivocal mitosis. So there are many pseudomitosis also, which we should be, I don't have a picture, but that we have to be mindful of, that fragmented nuclei or smudgy, thready nuclei. Those are not atypical mitosis. When you see nice tripolar mitosis, many multipolar mitosis, that's a sine qua non of malignancy. And many times we rely, these are negative. And then you can look at the surface dysplasia. If there is surface dysplasia, surface squamous epithelium is dysplastic with underlying atypical spindle cell proliferation, that again favors a sarcomatoid carcinoma. And sometimes immunohistochemistry, in fact, many times when the tumor is myofibroblastic in appearance, the immunohistochemistry is negative for epithelial markers also. Then we rely on P53 immunohistochemistry. And if there is diffuse P53 immunohistochemistry, that helps in favoring sarcomatoid carcinoma. So I think this is endless. So not only do we have to pay attention to the epithelial compartment, we also have to see in the stromal compartment, we have to look at the endothelial cells and not be swept away that these are glandular cells or atypical cells. The stromal epithelial cell, the stromal myofibroblastic cells also we need to take care of, that the ATPI is not over marked and not associated with any atypical mitosis. Then we also need to take care of the infiltrates, what type of immune cells are infiltrating. So just to show that sometimes there can be a lot of inflammation, but sometimes we can misdiagnose that as we can overlook the inflammation, and it could actually be here you can see sheets of lymphoid cells which look atypical, and some of them are multinucleate as well. But when you see cells which are atypical, hyperchromatic, and large, you can resort to immunohistochemistry. So this is a case where lymphoid markers were positive and CD20 was diffuse positive. So this is so sometimes you can have lymphomas where the immune component or the infiltrate can be overlooked, thinking that this is an inflammatory infiltrate. Okay, so and one of the ulcers that you can see in elderly and immunocompromised patients is in EBV positive mucocutaneous ulcers, where you can get these large variable sized, these sharply demarcated shallow ulcers with variable sized CD30 positive B cells, which are positive for Epstein-Barr-Eber-ish positive or EBV positive. Okay, so this was about the ulcerative lesion. So one of the things is that we need to be aware of the spectrum of the pseudoepitheliomatous hyperplasia and a lot of atypia that can occur, and sometimes the malignancy that can be hidden under the abnormal proliferation of the epithelium. Can we move to case 2, or is the time up?
Yeah, Munita, can I make a comment? I know
Yes,
we
yes,
had a
please.
1 hour. Yeah, we had a 1 hour extensive talk on ulcer. Nothing much to add also. But yeah, I would like any of the residents to comment on. Like, apart from the clinical history, what is the most important thing we pathologists would require to make a diagnosis on an ulcer? Apart from the clinical details that our surgeons provide, what is the most important thing from what she has been elaborating? What helped us to reach all the observations that we have done pertaining to this particular case?
Images.
What is the other? Yeah.
There should be some
Yes,
amount of
Jessley?
normal epithelium Like,
Very good. So Arzu, that is it. We need a representative biopsy. So we need from the margin of the ulcer with the normal epithelium, with the ulcer, and not a superficial one too. We need a well deep biopsy so that we can make all these observations. So thank you, Manita. We'll go on to the next.
Okay, so we'll be very brief now, I think, because there is not much time left. So case 2, who wants to discuss that? It's a 37-year-old male, operated case of buccal mucosa, now post-radiation, now has presented with an ulcerative lesion on the hard palate. And the clinical discussion is whether this is recurrence or whether this is something inflammatory. So we have a hard palate biopsy. Very quickly, Rishabh,
Yes, ma'am.
can you tell us what did you see? What are your findings? It's not moving.
Yes.
I think, is this okay? Can you quickly describe what you are seeing? I have not provided the surface epithelium, but this is from the lesion.
This region shows a nest of cells, multiple proliferating endometrial cells. Then we can see normal mucoid cells, SNI cells, and infiltrative cells are also being seen in this low power field.
Okay. So you're seeing inflammatory cells and some epithelial cells which are in nests, right? Is there anything at this power that strikes you?
Dilated duct in the center of the image.
Okay, very good. So you can see a dilated duct as well. And then anything else? About the kind of proliferation, do you think this is infiltrative or about this?
Looks like I'm separated, not infiltrative. There's no continuous spread.
Okay, okay. Okay, then we move to the next one. What do you see here? This is a higher magnification of one of the cluster. And what do we see?
I'm showing my metaplastic cells now.
Okay, so what we are seeing are solid balls of these cells or these epithelial clusters, which are small nests, right? And
Yes,
then
ma'am.
you also see some which have a central lumen, right?
Yes, ma'am.
And another remarkable thing, is there anything remarkable? Do you think this is infiltrative or is this invading these minor salivary glands?
No, ma'am. Because the architecture around is maintained. There's no infiltrative pattern as such.
Okay,
They are
so what
located in
is the architecture of this proliferation?
Tubular.
Lobular.
Yeah, very good. So this is mainly what you can say is a lobular architecture, right? Over here as well, you can see that you can almost draw a line around them. They are not marching everywhere into the tissue, joining tissues, but they're confined to this. The proliferation is somewhat confined here as well, right? So you can almost draw a line and you can have these as a cluster. It's like a colony of or a camp of these epithelial cells. So this is like a lobular architecture and it is centered around ducts. And what you can appreciate is that there are some which you said are metaplastic. Why did you say they are metaplastic?
Because the lining has been changed. I think they are salivary glands in which the lining has been changed to squamous cells. They're not looking normal.
Okay. So excellent. So if you look at these, the epithelium here, it has this kind of metaplastic quality to it. It has the cells as such are not showing too much pleomorphism. The cytoplasm is very pink and glassy. And if you see, they almost look like branches of a duct, right? And some of the structures have a central lumen, which looks like a duct, which is replaced, the lining is replaced by squamous cells. But the main thing about this is that if you look at, if you only have a snapshot of this in your biopsy, then this can look very infiltrative. So this is one of the pitfalls of this, that it can look very, very infiltrative. These small islands going everywhere can is a big pitfall where it can look very, very infiltrative. But what we did mention here, when we go to the lower part, we find that while if the biopsy is from here, sampled only this much, it can look very infiltrative. Whereas if you have a bigger biopsy, you can see that their architecture is lobular, ductal lobular, rather than infiltrative, right? So here also you can see that they look very pink, eosinophilic, and have a metaplastic quality to it, right? So there is still the cells are respecting each other and they are spaced out well, right? And there is a lot of inflammation. And here you can see this looks like a duct which is now stratified and has squamous lining instead of columnar lining, right? So what do you think this is?
Cytometaplasia.
Yeah. So this is what we have is the salivary duct showing metaplastic change, which is silometaplasia. Sometimes you can have necrosis as well as you can have extravasated mucus, and it is one of the condition in a small biopsy. It can cause real problems where because those nests can look really, really infiltrative, and this can also be associated with a lot of surface pseudoepitheliomatous hyperplasia. And what helps us is the architecture, the ductal centric and lobular architecture. They're centered in ducts, and even the metaplastic quality of the squamous epithelium, and doesn't have too much geomorphism. And many times you will have history of some injury or some trauma or radiation given to the epithelium, which leads to it. Dr. Anila, is Shiva there? No. Dr. Anila, do you want to quickly add something?
Yeah, nothing much as to it. I think in cyanometaplastia, even the clinicians will have a doubt of malignancy, no, Amunita? Like they also will be able to help us regarding, they may think that this is a malignancy. So when we are getting a biopsy, if we are not used to it, then there is chance we see cases being diagnosed as mucoepidermoid carcinomas because of that mucus glands also showing squamous metaplasia. So the basic
that's a
thing,
very
as
good
you
point.
said, is the low part where we diagnose that the architecture is maintained, and that also in small biopsy is extremely difficult.
Okay. Okay. Thank you. Do we have time for the other two cases, moderators?
Yes, Monita, you can go now. You can have quickly.
Quickly, okay. Yeah. So these were two cases which showed that you can have even benign conditions can look very, very ominous and can be misdiagnosed as squamous carcinoma or something else. Something can be missed also. So this is case 3. This is a 33-year-old cigarette smoker who had a nodular growth in the hard palate, and there is a biopsy from that. Kuljit, would you like to come in and describe this quickly?
Sure, ma'am. Ma'am, the very first thing I saw was I didn't see any pleomorphism. I thought it is just the hyperplasia of the squamous epithelium with the keratin pearl formation. There was one foci where I thought there are some acantholytic cells. But since the epithelium is intact, I can't see any infiltrating lesion. So I don't know. I thought it is just benign hyperplasia of the squamous lining.
Okay. Anyone else? Everybody agrees with Kuljit?
Yes, ma'am.
Arzu?
Ma'am, I felt there was a lot of keratinization and there are a lot of nests of tumor cells. I felt it was actually a tumor, ma'am. There are some cells which are showing a clearing of the cytoplasm that is present. There are some epidermoid appearing cells as well. And ma'am, there are the cells ma'am, at places they're showing a bit of hyperchromasia as well. No doubt abundant keratinization is present, but I felt a few areas were showing some mucin extravasation also. And ma'am, so ma'am, the slide that you're focusing right now, we see a lot of those cells with abundant clear cytoplasm that is there. And
okay.
So,
okay.
Again, here we have the islands of the epidermoid epithelial kind of cells that are there. So,
okay. Okay. I get it. So some of you feel that there is a lot of squamous proliferation. It is benign because of too much of hyperplasia, right? And the others feel that there is a tumor there with a lot of squamous keratinization, but a tumor. But all of you feel this is not a squamous carcinoma. Anyone feels that this is squamous carcinoma? Okay, so what we can obviously see in this slide is a lot of squamous proliferation. So because this is hard palate biopsy, when we see a lot of squamous proliferation, lot of these kind of irregular islands, very easy to spot keratinization. So our first reflex is to think of squamous cell carcinoma. And like Arzu mentioned that there is, what we do see is that the squamous, then we start looking at what kind of squamous epithelium do we have. If we see the squamous epithelium is pretty uniform. It is not typically looking very, very pleomorphic. We are not seeing any dark cells or hyperchromatic cells. And the other thing we want to see is there infiltration or what kind of proliferation is this? So at this part, you can see there are lots of islands, which are kind of which are irregular. They are all over the place. You don't have any normal tissue to see whether this is going into the invading into the normal tissue or not, but the whole lesion is full of these irregular shaped islets. There is without a doubt keratinization. And if we look at the epithelium is somewhat bland looking. It is not, here you can almost see squamous mature looking cells. And the keratin, if you see, is quite mature. And here also you can see, look at you can see most of the islands are squamous, right? But if you look at the cells, they are not pleomorphic, they are not hyperchromatic, they are somewhat bland looking, mature looking. And then you see more areas of these crypts are forming. There are these keratin pearls, large keratinous debris there. And then you start seeing these where there is some kind of material in this kind of some lumen with material. And here also if you look at the squamous, it again has that kind of a metaplastic quality. You have this very glassy eosinophilic cytoplasm, and you have these kind of somewhat these tubules which are filled with this squamous, or something similar to the silometaplasia that we saw in the previous case. But here you can see, I think we can all appreciate there is a tubule here, or there is a gland here with a lumen. Again, this also looks like that. So we're still struggling with what we have. And what I would like to tell you is that this was a pleomorphic adenoma with extensive keratinization. So I think I have a slide which is missing, but what it shows is basically you can see that one tumor that can show a lot of squamous keratinization, metaplasia, is pleomorphic adenoma. And in the minor salivary gland locations, especially in the hard palate, where the palate undergoes a lot of trauma, there is a lot of keratinization. And if we are not careful, and if we don't look at these tubules here hidden between this abundant squamous proliferation, we can miss it for squamous cell carcinoma. Like Arzu mentioned that she was seeing some mucin. There is no mucin. Most of it is mainly keratin. So it's a good point that at least you were thinking of something different than squamous carcinoma, and one of the reasons why I think this is not looking like a squamous carcinoma is because it does not show that kind of cytologic atypia and pleomorphism that is typical of squamous. So even if you see a lot of squamous proliferation, it is important to know that to distinguish it from squamous carcinoma, it is important to look at the cytologic atypia. You will not have a squamous cell carcinoma which is so bland looking, right? So awareness is important that some of the salivary gland tumors can show a lot of squamous metaplasia. In fact, a lot of squamous tumors, salivary gland tumors can show squamous differentiation. And the alerts in a biopsy are, it tends to show a submucosal tumor. Tumor cells are much more regular and uniform appearing. The stroma tends to be more hyalinized rather than desmoplastic and coarse fibrous. And sometimes you can have a lot of myxoid stroma that also looks less squamous carcinoma, and more salivary gland. So these are some of the alerts in a biopsy. When you have a big resection, it is much easier, but in a small biopsy, especially when you have a lot of squamous differentiation, it can be mistaken for squamous carcinoma. And pleomorphic adenoma, it very commonly shows squamous metaplasia, and it can show a florid squamous metaplasia with keratinization. We need to be aware of this. And pleomorphic adenoma is a benign tumor, whereas squamous carcinoma is a malignancy. So you can see a lot of myxoid stroma, and this is a pleomorphic adenoma showing this kind of keratinization. Then what can help is you can look for tubules here. You can see a lot of tubules in the background, and then you can also, again, you can see tubules. And you can do immunohistochemistry to see that the pleomorphic adenoma shows myoepithelial cells as well as ductal cells. So you can have this CK7 highlighting the ductal cells. And the myoepithelial cells are highlighted by S100 or any myoepithelial marker. See this, these are cases where you can have a problem. You can do immunohistochemistry, but first thing is you need to be aware that even pleomorphic adenoma can look like squamous tumor, right? So another tumor which is looking very squamous is, this is a tumor which looks very squamous, but if you look at the cells, they look very bland compared to what we see in a regular squamous carcinoma. It shows a lot of pleomorphism. So here, this is a mucoepidermoid carcinoma, if we know that mucoepidermoid has 3 types of cells, you have these mucous cells or goblet cells, you have these epidermoid cells or squamous looking cells, and some intermediate cells which have features similar to both or intermediate. So mucoepidermoid high grade mucoepidermoid can show a lot of epidermoid cells, a lot of squamoid cells, but it typically does not show any keratinization. And the cytologic ATPI is much less and much underwhelming compared to squamous cell carcinoma. It's like a subdued squamous carcinoma. So if your squamous carcinoma is looking very, very subdued and very pale and very cytologic ATPI is much less, please think of mucoepidermoid carcinoma, and then you can look for these kind of mucus cells which you may find and which can help you in diagnosis, right? So immunohistochemistry does not help between mucoepidermoid carcinoma and squamous carcinoma. And in most of the cases, you don't need to distinguish. Both of them are malignancies. So in the final resection specimen, you can make the diagnosis when you have more tissue. But if required, these can be separated on fish by doing fluorescence in situ hybridization for mammal-2 fusions, which are seen in mucoepidermoid carcinomas. Most of the mucoepidermoid carcinomas show this fusion, okay, which is usually not required in real life, right? So another tumor which can look like a squamous carcinoma, a salivary gland tumor is, anyone can guess what is it?
Myoepithelial.
Okay, so epithelial myoepithelial does not look like squamous carcinoma because it has a very regular tubules which are lined by dual layer, ductal and myoepithelial. And it does not usually show any squamous differentiation. So one tumor that can really look like a bland squamous carcinoma is a hyalinizing clear cell carcinoma. It can show very squamoid looking cells. These are all P40 positive, but if you notice the tumor looks very bland. That's one thing, and it does not show too many mitosis. So if your squamous carcinoma is not showing any mitosis, it is looking very bland. So think of either mucoepidermoid carcinoma or hyalinizing clear cell carcinoma. And hyalinizing clear cell carcinoma has a stroma which is hyalinizing. And usually it shows between the tumor islands, it shows a very hyalinized stroma, and around it shows this kind of desmoplastic stroma. So some people say that there are 2 types of stroma in hyalinizing clear cell carcinoma. The point I'm trying to make is that some of the salivary gland tumors can look like squamoid, and they can be mistaken for squamous carcinoma. And salivary gland tumors are much indolent compared to the squamous cell carcinoma. The prognosis is different, and sometimes your management may differ after surgery, right? So hyalinizing clear cells carcinoma is also P40 positive. So immunohistochemistry cannot help to distinguish from squamous carcinoma, both in cases of mucoepidermoid carcinoma, which is also P40, P63 positive, as well as hyalinizing clear cell carcinoma, which is also P40 and P53 positive. The thing is, this tumor is very bland, and it has hardly any mitosis or very low mitosis. It's a low-grade carcinoma. And FISH, if required, can be done if you need to distinguish it, because hyalinizing clear cell carcinomas are positive for EWS R1. Okay, so last salivary gland tumor, which can look like squamous carcinoma, which can look like a poorly differentiated squamous cell carcinoma, is any guesses?
Salivary duct carcinoma.
Very good. Whoever said that, excellent, because salivary duct carcinoma, which is a carcinoma which looks like a breast carcinoma, can when it is poorly, it's a high grade carcinoma, it may not show ducts. Then that time in a biopsy it can look like a squamous carcinoma. So this is one of the cases of salivary duct carcinoma which looks so squamous, and it can be mistaken for squamous cell carcinoma. And if you have not thought of this and not looked at tried to look for squamous differentiation, and you may not put the P40, this tumor, if you put P40, you will realize this is P40 negative. So squamous carcinomas are P40 positive, and if it is negative for P40, then it is not a squamous carcinoma. So then you can think of looking for glands, because you can get salivary duct carcinoma is an adenocarcinoma, and it can show just like breast. It also shows this intraductal carcinoma with this tomato pattern of necrosis. So if you're aware and if you're alert, then you can put immunohistochemistry, you can look for glands and comedo necrosis, and you can alert that this is not squamous carcinoma, but a salivary duct carcinoma. And then further, you can confirm with immunohistochemistry, these tumors are positive for androgen receptor. And like breast carcinoma, they are also positive for HER2 in about 25 to 40% cases. But they are not, unlike breast carcinoma, they are not positive for ER and PR receptors. So squamous carcinomas, it's not always that the malignancy that you see in the oral cavity is squamous carcinoma. Sometimes you will get other malignancies also. And salivary gland tumors, many of them will have a squamous appearance, and we should be careful. It could be a salivary gland tumor. So if your squamous tumor is very bland, if you find some goblet cells, if it is submucosal in location and the cells look very uniform, or the stoma is very myxoid or hyalinized, you can think of a salivary gland tumor rather than a squamous cell carcinoma. Right? I think we can stop here, sir.
Ma'am, only 2 more questions, 2 more cases.
Only one case is there. Do you want me to continue? It is.
Yes, ma'am.
Oh my God. Dr. Anila, is it okay if I continue and quickly finish the 4th case?
Please do, Punita. Please do.
Okay. Do you have any comments regarding the previous case? Because I think that
just
is
one small comment is that in the previous case that because I think the surgeon, speaking to the surgeon will be of use, unlike the necrotizing cyalometaplasia, because it was a palatal nodular, and he or she will be able to tell whether it is submucosal, and they may tell us that it is not looking like squamous cell carcinoma. Like that, maybe some helpful inputs from your surgeon. That would be helpful in such cases.
Yeah, I think that is
Yes.
an excellent point. The salivary gland tumors, even sometimes you can call it squamous carcinoma, but the surgeon can come back and say that this is not looking like a typical
It doesn't
squamous
look.
carcinoma.
Yeah.
It is very submucosal and the overlying mucosa is smooth. So that is a very excellent point that can help. And if that feedback is there from the surgeon, we should pay attention to that and go back and look for a salivary gland tumor that we may have missed. Okay, very quickly, whoever has not participated can quickly describe this tumor. A 31-year-old woman with an alveolar biopsy. Anyone who has been silent? Jacqueline, I know you have not been silent, but you can quickly describe.
Ma'am, the section shows tissue by stratified squamous epithelium, and in the submucosa there are inflammatory cells.
Okay, so the abnormality is hyperplastic squamous mucosa. There
Yes,
is,
ma'am.
do you think this epithelium here also is normal? At this power, maybe we cannot
No,
make
ma'am.
out, right?
Ma'am, it could
This
be
is
reactive, but it is not normal.
okay, okay. At least it is looking too much, right? The proliferation is looking too much. And what about this? What we see on high power?
Ma'am, there are islands of
Basaloid cells with peripheral palisading. And ma'am, the above image, like the above one showed the center cells giving us squamoid appearance. The center of those
Ma'am, here
Islands.
anastomosing cords are there. Cords
Very
and
Very good, very good. So what do you think there are lots of irregular islands, right? The periphery is much more prominent, and in the center part of these islands there is squamous differentiation, right? But which is very loose, and you can see a lot of spaces or desmosomes, and these are interconnected. These
reticulum-like appearance. Ma'am.
excellent, excellent. So and one thing in this, if you have only this much in a biopsy, this looks like invasive islands, right? You can see these islands are irregular all over the place. There is, so it's very important to have a low power appearance. Many times in a biopsy we will get very little tissue, but if we get only this much, we can think of this as infiltrating islands, right? But we need to be still careful. If we look at the epithelium, do you think it is malignant looking, or is it looking very
ma'am, it
bland?
is bland looking.
Yeah, so I think we all agree that this looks bland. So we should not only go by architecture, we should also look at the epithelium. And who wants to say what we can see in this? Okay, so
Ma'am,
what we
here
can
we can see anastomosing cords of cells, and these cells are mostly columnar to cuboidal with hyperchromatic nucleus.
Excellent, excellent. So what we do see are these islets which are interconnected, right? So there are interconnected islands as well as trabeculae, right? Where you have these
Yes.
cells, and the peripheral layer is much more prominent. They're looking columnar, right? So what that is referred to as is palisading, right? When the cells are standing next to each other and they're more erect, right? They are like a border, forming a border with parallel nuclei, right? That is called a palisading. So you can see most of the islands are showing palisading. Can anyone quickly tell me which are the tumors which show palisading?
Ameloblastoma.
Carcinoma, basal cell carcinoma.
Excellent. So one of the tumors which shows very characteristic palisading is basal cell carcinoma. Well, this is inside the oral cavity or in the mandible, so we are not talking about the basal cell carcinoma. So this is a tumor which is showing very prominent palisading. And then what do we see inside the epithelium?
Stellate reticulum, a loose
Yes.
network of cells that we can see.
Very good. So this loose network of these cells which look squamous in appearance and have a lot of intercellular spacing out, which is the cells intercellular junctions are loose and they look like stellate reticulum. And anyone wants to comment about these peripheral palisaded cells?
Reversal of nuclear polarity.
Reverse polarity.
Excellent. I have an excellent set of students today. They can pick up findings very well. So what we can see is reverse polarization. So can you, Subhash, can you tell me what is reverse polarization?
Ma'am, nucleus are away from basement membrane. Normally they are toward the basement membrane.
Excellent, excellent. So what we can see here are that if you look closely enough, I don't know if I have provided you a higher magnification, but even at this magnification, you can see that the nuclei are away from the basement membrane. There is a clear spacing underneath the nuclei, right? So this is a very characteristic feature of ameloblastic tumor. Reverse polarization, that is the nuclei away from the basement membrane, palisading, and presence of this kind of stellate reticulum. So just looking at the squamous epithelium is, we should not think it is a squamous carcinoma. We also have to see other tumors which can look very squamous. And ameloblastoma is one of the tumors which can, the stellate reticulum can look very squamous and can be mistaken for squamous carcinoma. And I showed you this case which had a lot of pseudoepitheliomatous hyperplasia, but there was underlying some nests which we could see retrospectively that they were stellate reticulum, where you can see this these islets. And this, so sometimes the ameloblastoma can ulcerate and ulcerate the overlying epithelium, and the epithelium can show a lot of pseudoepitheliomatous hyperplasia. But we have to look at the slides carefully. And whenever we see something like this, we should check with our clinicians and find out what is the radiology image, what are the radiological findings, whether this tumor is centered in the bone, and can anyone tell me where is the classical location of ameloblastoma? Okay, so this was from the mandible, right? So mostly it is in the posterior segment of the mandible, and you can also see it in the maxilla uncommonly. It's a tumor which arises in the jaw, but more commonly in the mandible. So your clinician will sometimes if they are very sure, most of the time they're very sure, it will be a smooth swelling. So overlying epithelium will not be like an ultra-proliferative tumor that you see in a squamous carcinoma. It will be mostly a smooth expansile swelling of the whole mandible. And the epicenter on imaging is bone rather than mucosa. And then you can see palisading, reverse polarization, and stellate reticulum. So these are the features. So do check before you call it squamous carcinoma, whether you are seeing some more features which are again, especially when you don't see too much of a pleomorphism. Ameloblastomas there can be ameloblastic carcinomas also, which is a much more challenging diagnosis, where it is very difficult to distinguish from squamous carcinoma because you can have a lot of pleomorphism. But features that will help in saying that it is ameloblastic carcinoma are reverse polarization and peripheral palisading. Okay. So these were cases where these were some lesions in the oral cavity which can be diagnosed as squamous cell carcinomas, but are actually something else. So there is the takeaway is mainly that you have to have a clinical correlation. You have to be in touch with your clinicians. If they come back, call you back and say, we think it is clinically something else, you have to listen. And it is good to always have a good correlation. And benign lesions can look malignant, and not all squamous malignancies. Some of the non-squamous malignancies can look squamous. So these were some of the cases. And Dr. Anila, if you want to add, and I'm very sorry that I have exceeded time.
Yeah,
by
nothing more
30
to add,
minutes.
Munita. Excellent talk. I would have personally liked to hear more from you. Excellent
Thank
talk.
you. You're very
As
kind.
always. As always.
Thank you. You're very kind. And great points that you brought in. And I think the students were excellent today. They actually probably didn't need
Yeah,
to.
yes.
They could pick up all the points.
Ma'am, there are two questions I can see in the chat box.
Okay.
What is the difference between denuded epithelium, ulceration, and erosion?
Okay. So denuded epithelium can be artifactual, or it can be procedural also. So when you don't have an epithelium, which is lining can be denuded. What is the other thing? Ulceration is whenever there is ulceration, you can have it is accompanied by reaction, right? So the body will always try to cover that ulcer. Immediate reaction is by forming an exudate. It will have a fibrinopurulent exudate, a meshwork of fibrin with a lot of polymorphs to try and plug that. So that tells you that that is an ulcer. And what else was the question? Erosion.
Erosion.
Erosion is basically a superficial trauma, which will lead to a lot of congestion, and the epithelium can be I mean, these are interchangeable things. I don't think you have to make too much distinction. So erosion is something which is clinically used mostly, and on pathology, you will mainly see that the surface is shed off, and there is some degree of reaction in the form of hyperemia lot of congestion, vascular congestion. So erosion is a milder version of an ulcer. And denudation is also when the epithelium is lost. Either it is because of a procedural thing or the artifactual, or if it is in vivo, then it will evoke some reaction.
Okay. Ma'am, another one is how to identify stromal invasion in small biopsies. Any clues?
I think this is the $1 million question. That is what we have to do to identify stromal invasion. What I find personal, so what it is basically both an interaction of the epithelium with the underlying stroma, right? So when there is malignancy and there is invasion, it tends to disrupt it tries to push into the stroma, and the stroma reacts. So it's a combination of that which tells you that there is invasion, right? Unlike a pseudoepitheliomatous proliferation, where it will be the epithelium may be abnormally proliferating. There may be a lot of architectural abnormality, but still the stroma, it does not invade into the stroma, so it does not evoke that kind of a desmoplastic reaction. So one of the very important factor which tells you that something is invaded is when it reacts, right? When it kind of induces a stromal reaction. And when those islands have gone too much deep into the epithelium. So a lot of combination of factors will tell you that there is invasion. So there can be some very bland tumors which can be problematic, where you have to, so when we say malignancy, we are basically trying to say whether something is malignant or not, right? A carcinoma or an epithelial tumor which is invading or not. So for that, we have to rely on architectural features as well as on cytological features, right? So in terms of architectural features, what tells you it has invaded is when it has just gone berserk, right? It has gone in all directions, marching. It does not respect the normal anatomy. It will push into the tissues, it will go into the muscles, into the underlying connective tissues, and it goes deep, much deep, right? So a lot of abnormality in architecture, which is much more than what you see in quantitatively a very complex abnormality architecturally, abnormal islands infiltrating. This accompanied by cytologic atypia, a lot of cytologic pleomorphism, which is unequivocal, right? And that is easy part. And then it causes, most of the times it causes stromal reaction. Problem comes in tumors which are very well differentiated or not associated with dysplasia, like the verrucous carcinoma, which doesn't have any cytologic dysplasia, but it is called malignant when it starts invaginating and pushing down into the tissues, right? And it can be very difficult on biopsies because you can have broad bulbous retifex which are just invaginating down without causing that kind of breakdown of the infiltrating the edge, but just pushing deep down. So there you have to rely on its invagination or its progress deep into the tissues rather than on cytologic atypia. So it is an architectural diagnosis, and it can be very, very difficult on a biopsy. And it is a recognized thing that you may not be able to clearly say that it is malignant verrucous carcinoma versus a verrucous hyperplasia or a proliferation which has a verrucous growth pattern. And for verrucous carcinoma, you will have to basically roughly take the adjacent epithelium as the baseline. If your apex are going beyond that, much deeper than that, then it helps. It favors a verrucous carcinoma. And if it had gone into the muscle and into the bone, then you're very sure. Another tumor which is very cytologically bland but can be very infiltrative is carcinoma cuniculatum, which is a subtype of well-differentiated squamous carcinoma. It can have cuniculatum by definition means that it burrows like a rabbit burrows. So it has an invasive pattern of infiltration where it forms these kind of tunnels, branching tunnels or branching crypts, where you have the epithelium as such is very bland, cytologically very bland, but the tunnels or those branching crypts, they go deep, they infiltrate deep down, and they are filled with keratin, and just like rabbit burrows, and they can go deep up to the infiltrate into the bone. So there are various factors. So there are subtypes which will have cytologically minimal atypia but are deeply infiltrative. They are reliant on the architectural features. And then there are tumors which are associated where you are distinguishing between a lot of complex proliferation versus invasion, where you are relying more on the desmoplastic reaction and cytological atypia. So it is case to case, a lot of factors come in. But these are the broad factors in which how you decide whether it is invasive or not. And mind you, there are a lot of other things which make it more challenging, like you have a tangential part, or whether you have a lot of atypical proliferation, like you have a verrucous proliferation. So those are challenging scenarios. In the biopsy, it is important to be aware of that, right?
Yeah, thank you, ma'am. Excellent talk, ma'am. And everybody appreciated, and thank you so much for taking so much of pain till 9 o'clock, ma'am. Thank you so much,
I'm
ma'am.
sorry.